interventional about respiratory. So not only gastro, I'm a gastro, so I do intervention also, but bronchoscopy and not only diagnostic but also intervention treatment is sometimes needed in some institution. And we have, for your information, we have very limited doctor who can do an interventional bronchoscopy at the moment. I hope that if you can come frequently in Indonesia, we can do some other workshop, and give your skills to our doctors, and maybe they can come to your country to see other maybe diagnostic or interventional therapeutic therapy for our doctors. So I think this is a very important session for our pediatric pulmonology. Not more than 100 that in here, because this is very subspecialty topics. So I hope you enjoy your stay in Indonesia. Thank you for Dr. Maudi also to be a moderator. And maybe sometimes we can go to your institution and have another interesting communication. Thank you again for Dr. Wahyuni, Dr. Arifan, Professor Dirk, and Dr. Maudi, and all the participants. I hope you can enjoy the lecture and have lots of experience with these two workshop and also lecture. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Safira. Indeed, interventional pulmonology is still a developing field in our country. Therefore, we need more and more practice to make more people, more pediatric respirologists skilled in this field. I would like to proceed to the first session of today's lecture that will be presented by Professor Dirk Schram with the title of Update of Interventional Bronchoscopy in Children. Prof. Dirk Schram is a professor from Heinrich Heine University, Dusseldorf. I hope I say it correctly. And he is very skilled in pediatrics, neonatology, and pediatric cardiology, as well as respirology. So, Professor Dirk, you will have 30 minutes to present your topic, and the time is yours.
Yes, thank you very much. You pronounced everything totally correct. So it is the Heinrich Heine University in Düsseldorf where I'm coming from. And unfortunately, I am only staying here for 2 days in this wonderful city with my first steps on Indonesian country. This is really amazing. And I'm very happy that you invited me to this wonderful clinic and this wonderful workshop until now. I'm honored to present something about the use of interventional bronchoscopy or interventional pediatric pulmonology. And let me try to share my screen for this, for my presentation. Okay. So I hope you can see now.
Yes, we can see, Professor.
The presentation mode of the, can you see the presentation mode now?
Yes, this is the presentation mode.
Okay, very good. Thank you very much. So, yes, I am pediatric pulmonologist, and my specialty is to do the interventional bronchoscopy a lot. And this is a kind of a new field in the respirology of children. due to the development of different technical things coming more and more available for the smaller applications, so that we are able to use different kind of instruments in the small airway of children. And the topic today is just to give you an actual overview of what we are doing there. I have some disclosures. I am also an advice for Karl Storz in Germany. So let me start with a funny introduction of a kind of funny introduction of an article which was published last year in Pediatric Respiratory Journal. It is from a colleague from Italy, and he wrote down that until a few years, the pediatric pulmonology was one of the most static branches of pediatrics. And now, in the recent years, it became one of the most dynamic branches. Something happened, and we see this changes not only in these different topics of pediatric pulmonology, like cystic fibrosis, the development of asthma, and things like that. We also see that in the field of pediatric interventional pulmonology. So what is pediatric or what is interventional pulmonology? First of all, before coming to the pediatric field. So let's have a look in this adult interventional pulmonologists. And they already defined a lot of procedures, a lot of skills, what are needed to become an adult pulmonologist. So look at these topics here. So routine procedural training is about flexible bronchoscopy, lavage, brush biopsies, the different biopsies like endobronchial biopsy and the transbronchial biopsies and the needle aspiration. Then there are these interventional skills like navigational skills, EBUS, CT bone CTs, robotics, and there are some advanced therapeutic procedures like using heatness or cryo or freezing inside the lung and using the stents. The critical care procedures are also using not only the chest tubes. This is something unbelievable until I did research on this field, that they have to know how to use chest tubes. They have to know how to use the video-assisted thoracoscopy, and they have to know how to use the rigid bronchoscopy. This is the adult pulmonology. So in the adult field, interventional pulmonology is well-defined indications, conditions of advanced procedural training and dedicated equipment. And in the pediatric, it is a bunch of rare conditions. It is a relative lack on procedural training. And of course, it is also a lack of dedicated equipment. So if we have a look into the literature, the last official statement of one of the biggest respiratory societies from the European Respiratory Society is a long time ago. This publication was from 2017, and they defined the pediatric interventional pulmonology as these contents, what you are reading here, or lung lavage, biopsies, transbronchial needle aspiration, etc., etc., etc. Also, the cryotherapy was inside there, 2017. And at the end of the statement, a statement is always something, a kind of a systematic review of the scientific literature. And at the end of this systematic review, they saw that there is a gap of knowledge in the scientific view of all these special contents of pediatric interventional pulmonology. So at the end, we do not have enough evidence of all these skills using in the child airway. So, I'm sorry. I'm very sorry there. I'm sorry, there is some problem with my PowerPoint. I have to restart it again.
No worries, Prof. You can restart the presentation. We'll wait.
Yeah, very good. It
Is
just needs
there,
a few
yep,
seconds. I'm sorry, it just need a few seconds. Yeah.
no worries, Prof. So, Prof, while we are waiting, so
Yeah.
so probably it will be in your slides somewhere there, but um I think we have right now we have almost 90 participants that are very eager to start a discussion with you. So if anyone wants to connect with you, so will you provide any email information for further discussion?
Yes, of course. It's no problem to I will hand over my email address and everything and all my connection possibilities so we can discuss
Sure, Prof. Thank you.
other.
So how about your presentation right
Yeah,
now?
I have it now. I'm sorry. I
No
continue
worries, Prof.
now.
No worries, Prof. It is a very interesting presentation.
So again, I'm very sorry. This is some
No,
okay. So okay. So let's go into a few seconds into the evolution of these interventional techniques. I think this is very interesting to understand where we are today. So as you all know, the flexible scopes were first built in 1964 in Japan, and this was the first flexible scope. It was 6 millimeter in outer diameter, 15,000 fiber cables were inside these flexible scope, and it took a while until the developmental of flexible endoscopes really started. The reason why it took a while was not because of pediatric pulmonologists have so much power and influence in these industry who are producing these things. The reason was something else. The reason was coming from the mobile industry. The first one was Martin Cooper. He developed the first mobile phone, 1973. And he's a lucky guy, as you can see on the photo. And the reason was that you can see what kind of development the mobile phone took in this year after. 1978, there was 14 years later, the first scientific publication of the usage of flexible scopes in the pediatric lung. And it was Robert Wood from Cincinnati who wrote this article. And the first reaction on this article was that a colleague from the US answered to this publication with the word, "This is the most distressing paper I have heard in my entire life. Flexible bronchoscopy is nothing but medical voyeurism, and doing this in children is the grossest of medical malpractice." This was 1978. And things in the developmental things of bronchoscopy did not stop while there was so much things going on. And what was going on? 1999, there was the first mobile phone developed with the handy camera. And this camera technique was one thing why things suddenly came very fast. So in 2002, there was the first hybrid bronchoscope, a mixture between fiber optic and digital bronchoscope, which was an outer diameter of 3.6 millimeter, and this was the first hybrid scope for children. 2009, we had the first single-used bronchoscope on the market, and the first computer navigation system was developed since 2009. 2014, we have the first full digital children bronchoscope. And then 2018, the first iPhone was on the market. No, it was not the first one. It was the first iPhone with a full HD camera. And now you see 2019, we had the first 1.1 millimeter cryocatheter. And already 2020, we had in this little country of Germany, we had already 11,733 bronchoscopy procedures in the childhood airway. So in the US, the all amount of bronchoscopies 2022 were more than 500,000. So something was happened very, very fast. And in Germany is since 2023, we have the first single-use bronchoscope with an outer diameter of 2.7 millimeter, which is only 250 euros costs. So as you can see here, the technique becomes cheaper. The technique becomes smaller. And because of this availability, also in smaller countries, in smaller clinics, also in smaller departments, these availability led to the thing that procedures becoming more and more and more. And with the procedures, the colleagues are more aware of how to use it and what do they need also for the interventional things. 2024 was the first clip produced, which is able to repair tracheoesophageal fistulas only by using an endoscopic technique without any surgery. So this is the way we are going in the past 60 years of endoscopy. So the endoscopy is all about, the interventional skills are all about biopsy, restoration of airway, patency, and some news I want to show you. First of all, the main thing in the interventional stuff, and this is one of the oldest skills, is doing some transbronchial or endobronchial biopsies. So the most common indication, therefore, where we had is to look in children after lung transplant to see if there is any graft rejection after lung transplant, or to look if there is any diffuse disease of lung parenchyma, for example, some interstitial lung diseases. As you know, these are really rare conditions. Even transplant is very rare in childhood. And with the new medication for cystic fibrosis, it becomes more and more rare that lungs are transplanted in childhood. And the ILD is also a very rare disease. So the fact is that it is not done very often on the one hand side, and on the other hand side, the forceps using these biopsies are mostly not very good to have such a good biopsy that the pathology is making a good diagnostic after. So we had until now no data about the diagnostic yields in the pediatric airway. So what is new? What are we doing today? There is, in this year, 2024, the working group from Cincinnati, from the US, published their first publication, their first work about biopsy, how they perform biopsy today. Because of two different techniques, which are new in the interventional field, there is a possibility to reach also solid lesions inside the lung with navigational systems and the radial ultrasound. So they compared two different techniques. The first technique was they wanted to know how good the diagnostic yield of EBUS is. You know the EBUS system, EBUS TBNA, it's the needle aspiration, while using an ultrasound system is using in the adult pulmonology very, very often. In childhood, it is rare because of the huge diameter of the bronchoscope, which is, for example, the Olympus bronchoscope, which can EBUS is 6.7 millimeter in the outer diameter. So children are normally older than 11 to 12 to 13 years old when you like to perform it. So there are some publications about using EBUS to make some good lymph nodulars, for example, lymphoma, or for any tuberculosis. What we do not know is how good the navigational system is. And what do we need for the navigational system? So we need the lesion, we need a CT scan before, and we need a special radial ultrasound system to have a good situation where this lesion is. And this is what they tried to do their research about. So the indication of these biopsies were pulmonary nodules and hilar and mediastinal lymphadenopathy. And the pulmonary nodules were done by CT navigation and radial ultrasound, and the hilar and mediastinal lymphadenopathy was done by the EBUS. The diagnostic yield for these EBUS, and these are the results, was good with 76%. And this is quite an interesting number, 76%, but compared to the invasivity of this technique, it is quite low. And the diagnostic yield from the radial EBUS combined with the navigation system was 85%. And this is a really wonderful number, 85% in radiation in this radial ultrasound system and CT navigation system means that these children do not need any open surgery anymore when we have such a good diagnostic yield. These results in these biopsies were infections, malignancies, sarcoidosis, and they looked very special at the infections, and they saw 31 pathogens, and there were 18 found in the bronchial lavage, and additionally 14 more found in the EBUS, radial EBUS transbronchial biopsy. And this is very interesting. The interesting thing is, as you can see here on the left side, the green field shows that at the end, the significant pathogens were much better if you are targeting this lesion inside the lung than doing only the bronchoalveolar lavage. So this is modern, this is new kind of not indication, but it is a new kind of technique in these biopsy thing, and it could mean that maybe the biopsy is something what will get more interesting in the future. The other thing is the recanalization, and as I showed this morning in the hands-on workshop, the recanalization is also done by cryobiopsy. We have some good cryo data in childhood in the moment. We have, for example, comparing the transbronchial lung cryobiopsies, we have different case reported from, for example, Ashkan from Kuwait, or me, or different colleagues from India, for example, who provided their data to the publications, and we saw that the diagnostic yield and the safety of these kind of cryocatheters in the lung using the cryobiopsy is very good. For the restoration of airway patency, we have two different techniques. The one technique, which is the frying it, that means we're using heatness for laser or electrocautery, and the second one is using the cryocatheter for making a recanalization. And also for these special data, using cryo to make a recanalization, we have good data on the safety and efficacy of this technique. So the modern way to open the lumen of the airway is nowadays more and more doing it while using cryocatheter. The other possibility, which is also an additional skill, of course, is to open the lumen while using balloon dilatator. Here you see a performance with me in our operation theater, and you see that it is sometimes tricky to work on this small airway with so many hands using these special catheters. We did some research on it also, and we saw for using the balloon dilatator, the success rate is only 65%. Of course, the success rate is associated with the Kaplan-Meier grade. That means if the Kaplan-Meier grade is higher, the success of dilatating the airway is decreasing. And this is a matter of timeline. Then the significant more successful in children with acute stenosis. That means the earlier you are in this airway and open the airway, the better it is for having a successful reopening of the airway than if you are trying to dilatate more chronic or mature scars. So you have to look for the adequate patients. You have to explain the procedure to your team, what happened if any complications will occur, and you think about you have to share the airway with the anesthesiologist, and of course you need any general anesthesia therefore, so you need the OR, you need a complete relaxation, and you need the right equipment. And if you have any complications, for example, if you do any kind of laceration of the airway and you have in the end you have any mediastinal emphysema, for example, you need a plan B what to do with these complications. The next step is what is always discussed is what is new in this stent field. The stents are nowadays more and more getting biodegradable. That means this is a special kind of material which is called polydioxanone, and these special things are falling into water and CO2 after a time of 14 to 15 to 20 weeks. So normally we say after 3 months, these biodegradable stents are not anymore in the lung. So as you can see here, they are custom made. So you have to measure the airway. You have to measure these data giving to the special custom made companies. So they are producing these things, these stents for you. And we have some good experience from the gastros. And for example, as you can see here, there are some good publications about that. This is a review. This is also a little older, 2020, in the Journal of Pediatric Otolaryngology. And you see here the most indications for using stents are the severe form of tracheobronchomalacia. And in most cases, the severe forms of tracheomalacia are because of any cardiovascular anomalies. So you have this short-term improvement, which is mostly less than 3 months, and you have less good long-term improvement. So this is not very good. A long-term improvement only about 34%. And the complication rate is high. It occurred in more than 20% of all cases because of fragmentation. The degradation of the stent does not happen in 1 second, like in a finger clip, like something like this. It has happened on different areas of the stent, and it needs some time. And this, therefore, different fragmentation resist, and these fragmentation leading to foreign bodies. And of course, there is a small rate of complication due to granulation tissue migration or stenosis. So the ERS statement on tracheomalacia was published 2020, and they already said that the restoration of airway patency improved clinical situation before trying surgical repair or placement of a definitive stent. Therefore, the biodegradable stents are the way to go. So you want to have a bridging treatment. You want to have to look if there is improvement of the airway lumen, just do your stent, because the complication rate of these definitive stents from metal, for example, there is a complication rate much higher. There is another older technique, and the older technique to dilate the trachea, for example, is a rigid bronchoscopy. And as you can see here, me performing the rigid endoscopy just while using the rigid optic. There are different possibilities just to have a look and open the airway. And this is easy because using the rigid scope for dilatation means that we know already all diameters of rigid bronchoscopes. So you can see here the weight of the child, the external diameter, the internal diameter, and you can choose sizes for dilatating the airway while using rigid scopes. This might be much cheaper than using any expensive dilating catheters. But of course, this is only working for central airway stenosis. This is a classical technique we try to do today. The rigid scopes are using nowadays in the interventional bronchoscopy for bridging the ventilation possibility. That means having a secure and safe airway and then using flexible catheters and the flexible scope inside the rigid scope. So what is new? What are the new things? The new things are valves and clips. These are the new things. So first of all, we have valves. These special valves are doing for treatment-persistent air leakings. This is a really rare disease, and it's almost needed if you have a severe form of pneumonia, a severe form of lobectomy, and after this lobectomy, you have a persistent air leak, for example, where you need to close this air leak. So I don't want to have too much time on this, but this is something which is needed in the adult way very much often more than in the pediatric way. And these special valves are using inside the identified bronchus which led to a leak. And the other thing, here you can see, first of all, the graphic for using them inside. And the other thing is using, as I told you initially, the clippings. And the clippings are used from the esophageal side to put inside the, to identify on the esophageal side the beginning of the fistula, and then putting these clips from the esophageal side and clip the opening of the fistula so that it's closed. These clips are leaving in this position for about 3 months, and then they are falling out, and then you can they can just go in the GI tract, coming out with the stool. So maybe this field of endoscopically treatment of tracheoesophageal fistulas is something new, what led to the possibility that not all children 1 or 2 days old need pediatric surgeon in the future. This is a result of 2 departments coming together, the gastros and the respirologist. And you can see these development worldwide, that big clinics with a huge amount of specialties are trying to make a commitment which is called the aerodigestive centers. And these aerodigestive centers, including all these subspecialties like pediatric surgery, the gastros, the respirologist, the speech therapist, etc., and they are all running around these children trying to get new ways to treat inside the lung. So at the end, the largest object that the pediatric interventional bronchoscopy can remove from the airway lumen is the thoracic surgeon, of course, and it's also the adult pulmonologist. I don't know if Dr. Eric is inside the Zoom meeting, but I'm sorry for that. But we have to be strong for our own patients, and I think this is the reason why we have to get familiar with that. So how can we implement pediatric interventional pulmonology in this field of pediatric pulmonology? And let's have a last look into the literature. 2024, it was published in the Pediatric Pulmonology, and they make a survey in the US and ask the pediatric pulmonology fellows how much are they familiar with these different skills like endobronchial brushing, biopsies, like stents, like cryoextraction, etc., etc., etc. And as you can see here, there were lots of skills who are not familiar in different clinics. So that means if we want to have a new kind of fellowship, if we want to make a new kind of interventionalist like the adults do, to become an interventional pediatric pulmonologist, we need a good cooperation. We need networking. We need to know in which clinic of your country is performing what kind of skills, and where can I send my fellows to learn these special skills. And the first step in this coming together and building networks is doing some collaboration, doing things like presenting on the huge society meetings, conferences like the ATS and ERS, like tomorrow at the WABIP, and to present all these things. Because talents win games, but teamwork wins championship. And this is the end. And let me just tell you that also one step was to introduce or to initiate the first interventional pulmonologist hands-on training this year in my university. And this was such a huge success that I decided to follow up this training next year again. So this was my talk. Thank you very much.
Thank you, Prof. Stram. We have a very interesting lecture from you, very eye-opening, that we can do a lot in this field that will help our patients. I would like to greet all the participants for today's lecture. We have almost 100 participants coming, listening to all the lectures from all the experts. I hope you all enjoy our lecture for today. I would like to proceed to the next session of the scientific session. Our own pediatric respirologist is going to present experience in Indonesia, foreign body extraction and cryotherapy application. I would like to welcome Dr. Wahyuni Indawati, a consultant of pediatric respirology. She is currently the head of pediatric division, the head of a respirology division, pediatric department in Universitas Indonesia, Cipta Mangunkusumo Hospital, and she's currently the head of respirology task force, Indonesian Pediatric Society. Dr. Wahyuni, the time is yours. You have 30 minutes to present your topic.
Thank you, Dr. Maudi, for a very nice introduction. Let me share my screen first. Okay, is it?
Yes, it is visible.
Okay, thank you very much for confirmation. So, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. I think this is a very good opportunity for us today because it is not often we will talk about the pediatric bronchoscopy and interventional pulmonology, and it is an honor for us that we have international guest lecture here, and also Dr. Irfan Fauzi, our colleagues from Harapan Kita Hospital, that he will also share his experience in doing the pediatric bronchoscopy and interventional pulmonology. I think as mentioned with Dr. Maudi, that actually the pediatric bronchoscopy and interventional pulmonology is a very rare procedures that is doing in other hospital. So maybe Cipto Mangunkusumo Hospital and Harapan Kita Hospital is the pioneer of doing the bronchoscopy and interventional pulmonology in Indonesia. So maybe I just want to share a small experience of us when we start doing these services in our hospital. So as we all know that the flexible bronchoscope was first invented in 1966 by a Japanese doctor, Shigeto Ikeda, as already mentioned by the previous speakers. But since then, we know that the development of which and its related item has been growth very rapidly, and in the recent decades, and we are, as the pediatric respirologists, often deals with a large number of common diseases that is affect the airway and the lung parenchyma. That is why we need tools that will help us to manage those diseases. And as a pediatricians, we also will deal with a wide range of ages, from the preterm newborn infants into the adolescents. And as the consequence, we will need a lot of equipment that will help us to do the procedures with different size of the children, which is sometimes make challenging for us while we are working in developing countries like Indonesia, where we are very limited resources. So I think it is already mentioned many times that while there is no absolute contraindications for the bronchoscopy, the indications is divided into two main aspects. The first one is to diagnostic aspects, like to explore the airways and also to obtain the biological samples to help us diagnosis of pediatric respiratory diseases. And nowadays, the therapeutic aspects is developing, as mentioned and explained very good from Professor Dirk. So maybe just for me, the task is only to tell the stories from our centers. So we just began or started in 2015 for doing or performing the pediatric bronchoscopy. So until now, we have done for more than 1,000 procedures, and about 49.8% were done in the intensive care unit, whether it is in the PICU, NICU, or in the cardiac intensive care units. And the procedures that we have already done is the classical diagnostic procedures, like the flexible bronchoscopy with the BAL, brushing and biopsy, also the foreign body extraction. We perform cryotherapy and APC, and also the balloon dilatation. And most of the indications is like the atelectasis, unresponsive pneumonia, difficult to win ventilator, or endobronchial mass due to many etiology or the tracheobronchial stenosis. As mentioned, that this is the basic bronchoscopy techniques. It is a bronchoalveolar lavage. So it is a diagnostic procedures used for recovering cellular and non-cellular components of the epithelial lining fluid of the alveolar and bronchial air spaces. So we will do the procedures by using the flexible bronchoscope and then wedging the scope into the targeted segment of bronchi and instill some nasal saline there. And then we expect that we have 40% of recovering fluid to be checked for the cellular and non-cellular examination. So I recall this is our first, actually my first experience of doing bronchoscopy in children back then in 2015. This is a 2-year-old boy with the biliary atresia post-liver transplant. And the patient had a very severe sepsis and pneumonia, and also the right lung atelectasis. So we performed some bronchoscopy and also the BALs, which reveal a lot of opportunistic infection coming from the result, as the tuberculosis, CMV, Candida, and also the pneumocystis jirovecii for the patient. Another procedures is the endobronchial biopsy. It is procedures to obtain the samples of the superficial airway structure, like the epithelium, basal membrane, and smooth muscle. Conventionally, we can use the brushing or forceps. It is help us to diagnose the granulomatous disease, endobronchial tumors, or chronic fungal disease. So this is like our case of 9-year-old girl with the chronic cough, weight loss, left lung atelectasis. And when we performed the bronchoscopy, we found that there is a granulomatous mass in the left main bronchi. And we performed the endobronchial biopsy. That the result is the granulomatose consistent to the tuberculosis. Another procedures that can be used nowadays is the cryobiopsy, whether it is the transbronchial biopsy or the endobronchial cryobiopsy. I think it is already mentioned by the previous speakers. For the transbronchial biopsy, usually we need it to obtain a sample from children with diffuse lung disease or the ILD, and the procedures will do by passing through the cryoprop into the flexible bronchoscope, advance into the lung segment, and it is stated now that it is we can collect larger biopsy size and lack of cross-active effect doing this cryobiopsy compared to the conventional transbronchial biopsy. And for the endobronchial cryobiopsy, it also showed the higher efficacy in diagnosis of endobronchial mass compared to the conventional forceps. So what we've done with the cryo in our hospital is like this patient, 2-year-old boy with the tracheal bleeding, the blood clot, which occluded 75% of the carina and extended into the truncus intermedius, and then we evacuate the blood clot using the cryotherapy, and fortunately the bleeding also can be stopped by using the epinephrine. Sometimes we will need the thermal therapy, but we didn't do it so much or so frequent in our hospital. Maybe Dr. Rifan will explain more about the thermal procedures in his hospital. So this is a 11-year-old girl with left lung mass and atelectasis, and the main left bronchus was completely occluded by the endoluminal mass prone to the bleeding. We performed the bronchial wash, bronchial brushing, and also the cryobiopsy. And at that time, the bleeding was controlled using the epinephrine and also the EpiC. Sometimes we will also need an airway balloon dilatations for alleviating the airway stenosis, which it can be caused by a congenital or acquired etiology. And the most common cause of acquired airway stenosis, like in our hospital, is due to the endotracheal intubation, resulting in 90% of cases. So this is a 4-month-old girl who came to our hospital with the grade 3 Kaplan-Meier stenosis subglottic. And then we performed the balloon dilatation for the patient to treat the stenosis. And sometimes we do it combined with other procedures like cryotherapy to do the devitalization, or sometimes to do the cryo extraction for the granulation tissue if it is found. And about the foreign body removals, we all know that the rigid bronchoscope is still considered the safest instrument in most pediatric centers because it has a lot of advantages. But nowadays, the flexible bronchoscopy is getting more popular because it has also advantages, especially in cases of distally wedged foreign bodies, and also in some cases with the mechanically ventilated patient, or cases with the fractures in the spine, jaw, or the skull. So I think the characteristic of foreign bodies aspirated by children can be different across the continent, but I think more of the report still report the most common locations is in the main bronchus, either it's in the left or the right bronchus, and the severity of the symptoms of the aspirated foreign body also will vary depending on the site of the infection. We also see that actually there is a systematic review about the using flexible bronchoscopy to remove the foreign bodies from the pediatric patients, which show 87.1% of a successful removal, where the complication rates very low. So I think nowadays a flexible bronchoscopy can be also a tool that is feasible and safe for the extracting the foreign body aspiration. However, we will need the multiple modalities for foreign body extraction depending on the type or the object of the foreign body itself. For example, we will need the grasping forceps, we will need a basket for smooth objects, sometimes we need nets, sometimes we need snares, or even we can do using the cryoprobe, especially for the water-rich material. Maybe I will show you just one video that show flexible bronchoscopy for foreign body aspiration in children.
Dr. Wahyuni, right now we are seeing video without any sounds. Probably would like to annotate some of the videos that some important points of the video. Probably what you would like to guide the participants on what is the video about, because there's no sound right now.
Information is there in the video, how the procedures is done. Using the flexible bronchoscopy, so sometimes we need more than one modalities to extract the foreign body aspiration. That means that we always have to be prepared for anything that can happen. So very important to have procedures. Also, after doing the procedures, it's very important to do the post-bronchoscopic evaluation. Segment or segment, I mean, just to make sure that everything is good. There is no residual foreign body aspiration. I think the summary for my talk today is about the flexible bronchoscopy represent an essential diagnostic and therapeutic tool when we managing patients with complicated and difficult to treat respiratory disease. And we know that there are various methods of bronchoscopic sampling technique to obtain the samples. And also the recent advances in interventional bronchoscopy showed promising results to help us managing various complicated pediatric airway disease. The procedures relatively safe to apply in children and complications are rare. Of course, all this doing this training is important, and experience will make better performance. So with that, I thank you all for your attention. And this is our team in Cipto Mangunkusumo Hospital. Thank you, Dr. Maudi, for the time.
Thank you, Dr. Wahyuni, for sharing the experience from our hospital. It shows that, it proves that interventional bronchoscopy or interventional pulmonology procedure is very helpful in managing patients. And I hope that all participants today, more than 100 participants attending this meeting, are opened by more possibility that can be served to our patients. Next, I would like to invite the third speaker. We already heard that there are two terms in regards of interventional pulmonology, freeze or fry. So using a cold or using heat. We already hear the cold side or the freeze side from Dr. Wahyuni, which is the cryotherapy. But how about the heat, the thermal therapy? I would like to invite the third speaker, Dr. Irfan Fauzi, as the consultant of pediatric respirology from Harapan Kita Women and Children Hospital. He is currently the head of respirology division, Child Health Department in Harapan Kita Hospital. Dr. Irfan Fauzi, are you ready with the presentation?
Okay, Dr. Maudi, I'll try to share my my slide first. Is it shown?
Yes, it is visible.
Okay.
You have 30 minutes for your presentation.
Okay, thank you, Dr. Maudi. Thank you for having me in this lovely meeting, and also I'm welcoming Professor Sham to Jakarta, Indonesia, and I'm so delighted and I'm so happy to hear your presentation that makes another experience, the good experience for me and for us especially to regarding the interventional pulmonology in children. Okay, as Dr. Maudi mentioned that my talk will be the thermal therapy in pediatric respiratory disease, but maybe I want to limit my talk only for two thermal therapy in pediatric. That is laser and APC. Yeah. Because that was there were the most usable modalities in our interventional pulmonology. First of all, I would like to introduce that the history of our pediatric placebo services in our hospital is a government-owned National Women and Children Hospital. We started the flexible bronchoscopy in 2012. And at the time, we only do the diagnostic procedures mostly. But recent, we beside the diagnostic, including EBUS, but also the therapeutic or pediatric interventional pulmonology, we have APC, cryotherapy, and holmium laser. And we also do the exit procedure together with the obstetrician that have a patient with certain cases such as congenital diaphragmatic hernia to do the bronchoscopy guided intubation. And our venues during the bronchoscopy, there is three venues. One is OT for diagnostic for the high risk babies, and therapeutic also in the OT. And we have also a special center for diagnostic only. At the moment, we do the diagnostic only, but in the future, we will be doing all the bronchoscope here done there. Yeah. And also in bedside in NICU and PICU. This is maybe already mentioned by Professor Fram and Dr. Wahyuni. So I have to pass the slide because the most important thing that we have to expand our services, like Dr. Wahyuni said in her presentation, that Indonesia actually we only have a few pediatric pulmonologists that's doing the flexible bronchoscopy, but it is our jobs to make more pediatric pulmonologists doing the bronchoscopic in their own centers. The advantages of interventional pulmonology that we already know that it will shorten the hospital stay, reduce pain, and quicker recovery times, and minimal scarring. And also at IP, we do personalized treatment plans to each children's unique condition. We also enhance the overall quality of life for patient and their family. Later on, we will discuss about this statement. Yeah. In line with the development of advanced medical technology, the trauma therapy has assumed a prominent role with an expanding approach of interventional pulmonology and represent the therapeutic modality frequently employed. And the two most common indications, the airway obstruction with endoluminal disease and bleeding. As I said earlier, that I'm going to focus mostly about laser, and then second will be organ plasma coagulation. Laser with as stand for light amplification by stimulated emission of radiation. The theoretical basis was stated by Albert Einstein, and then it become more develop the laser later on. And also the usage, we do it in the medical field also. Medical lasers operated in continuous wave or pulse wave modes, as measured as watts in continuous wave, and the pulse lasers is measured as energy or joules. We have also the density, a power density refers to laser power per unit area, and energy density with radiance is multiplied by exposure time or joule per centimeter square. I think, yeah, the interaction between the laser and the tissue is determined by the wavelength, the power density, and the exposure time. As sure, yeah, for sure. The wavelength also determines the depth of penetration. In the short wavelength, the light of the laser will be scattering more, and but limits the depth of penetration, such as argon laser is used only for the retinal surgery and port wine but max as example. Yeah. And the longer wavelength would be have a greater depth of penetration, especially an example, for example, is Nd:YAG lasers operates the cutting and coagulation of the tissue. This is the wavelength of the lasers type from the 300 light as a like ultraviolet, and then the other near infrared and mid infrared is become the longer wavelength. And this in our hospital we have the YAG holmium YAG, yeah, which is nearby to mid infrared that can more penetration, deeper penetration, and cutting also. This is the characteristic of the different lasers as a comparison. And Nd:YAG is quite good in the cutting, but the most powerful cut is in the laser CO2 laser, and the coagulation is as good as the better is the Nd:YAG, and the tissue depth also the Nd:YAG, as mentioned in the previous picture. The medical use of laser, usually we can use it in the rigid bronchoscope or the flexible bronchoscope. And the medical use laser is doing for the cases of choanal atresia or recurrent respiratory papillomatosis or saccular cyst, gloating scarring, subglottic stenosis, and we have very plenty of cases of post intubation subglottic stenosis in our hospital, and almost all of them are referred from our neighbor hospital, uh, heart center, Harapan Kita Heart Center, cardiovascular center, and most of them are after post intubation after the surgery. Yeah. And we also have some of them is a glottic hemangioma and a granulation tissue in the airway. This is the indication, yeah, such as for the cases of iatrogenic mucosal injuries like web-like structure or granulomas, uh, or any granuloma in certain or stent related granulomas, which is I myself haven't seen the case because we do not have stent placement in our hospital. And also in the recurrent tracheoesophagus and airway angiomas or airway papillomatosis and various types of tumors, and mostly are benign tumors. Or for cases such as congenital severe laryngomalacia, subglottic stenosis due to the granulation form, or hemangioma, subglottic hemia, and subglottic cyst. This is a paper that my professor Wen Jisong, I learned so much from him in the Taipei. He's doing the laser supraglottoplasty in the cases. Most of them is laryngomalacia, uh, and the result is quite good. Yeah, and the risk and complications of laser usually like other flexible bronchoscopy procedures. Maybe the patient will having hypoxia or bleeding, perforation, and the last but not least is the fire in the airway. I have one case with the fire of the airway, but I will show you not this. Oh, sorry, this is quite. This is the complication. I would like to show you the complication of the laser. It's lesson a very it's very good lesson for us. In this, it is the first time, but I hope it is also the last time that we have. It's a case of tracheal recurrent respiratory papillomatosis, a child 3 years old at that time with a severe recurrent respiratory papillomatosis with tracheostomy. We're doing the lesson by with we intrude the flexible endoscopy to the tracheostomy. Now that is the flame, and thank God the patient is okay. Only the inside of the tracheostomy canal has have a the gelaga in Indonesia, yeah, the black spot in the inner of the tracheostome, but the patient is fine. This is the burn tracheostomy, but the trachea is fine. Yeah, the patient also is fine. What is what was the lesson to learn from this case? We playing with fire, then we have to prepare. There is a possibility of the flame or the burn, the airway burns. Yeah, and I think the analysis of the case is maybe at the time I was accompanied by our anesthesiologist, and maybe there are more oxygens or that being pumped in the tracheostomy than at a time when I started the lasers, and the plenty of a bunch of oxygens will be would make the fire come. That is the case, and this is I want to share to you with you is laser supraglottoplastic. You can see the curly epiglottis, and we have also found a shortened area epiglottic fold, and then we make a excision in the area epiglottic fold with the laser, with the holmium laser. We're doing the both side, right and the left, yeah. And the third video is a re-evaluation of the third day after the laser procedure. It's still light arytenoid edema, but the clinical symptoms is improved, and there is no stridor in the child anymore. This is also the subglottic post-intubation subglottic stenosis. You can see there's more than 90% of the obstruction subglottically due to intubation, and we make an incision in the section of the granuloma form in the subglottic with the laser, and we're doing also after the laser we're doing the balloon dilation to make the the lumen is wider, yeah, wide open. It's also a multi-level subglottic stenosis due to intubation. After intubation, as we can see, subglottically we have one level and in the proxima and others in the distance. And we do also the laser section of the granulation form. And after that, we perform the balloon dilation to expand, to extend to widen the subglottic area. This is after the procedure. The stenosis is already gone. And the second one, I want to talk a little bit about argon photocoagulation, or APC, that is a non-contact technique. The laser is a contact technique, and the APC is a non-contact. Utilize the argon to introduce coagulation or tissue debridement. We can also use the flexible or the rigid bronchoscopy, and the probe is activated with the pedal, and the gas flows from the probe. Once it is in contact with the electric current, the gas ionizes and transports electrons to surrounding tissue at a very high frequency. This process causes a thermal reaction with subsequent cellular damage. It's counted that the APC is only safe also, and the complication rates are low, but the risk is the gas embolism or airway perforation. Me myself has not much doing the APC. We do mostly resection with combination of the laser or combination laser and or with cryo. This is a case, a girl, 4-year-old girl with a severe respiratory distress, and we can see that is the right lung atelectasis, the right hemithorax is not expand, and this is the bronchoscopy finding that this is the first procedure. As we can see, there is a tumor that totally blocked the right main bronchus, and we're doing the excision of the tumor or debulking with the snare, the APCU snare, but we cannot do it with only one procedure. We do it several times to remove the mass, and we also doing the cryotherapy for the bleeding that has already happened during the procedure of the excision of the tumor. This is the previous X-ray, and then this after the procedure. Yeah. This is the difference of laser with an APC. That laser is uh, they all have advantage and disadvantages itself, and the most important thing, the laser is very expensive compared to the APC or electroculture. And then the special consideration is the fire cannot in the laser we have to more be careful due to the possibility of the airway burn to the fire. So we have to make a good teamwork with the anesthesiologist if we want to put the laser on, and we have to ask them to increase the supply of the oxygen. And we have reached the end of our talk. My talk as a conclusion, thermal therapy procedure is one of the interventional pulmonology approach, including in pediatric population. It is safe and as effective modality for respiratory disease in pediatric. The utilities are now increasing worldwide, but in Indonesia, the use it is in pediatric population is still underdeveloped, and it is our job uh, uh, to make the usage of the thermal therapy is more used. Yeah, I think that's all for my talk. Thank you for your attention.
Thank
I'm
you. Thank you, Dr.
giving back
Rifan,
this.
for
Yeah.
a very nice presentation, sharing your experience in interventional pulmonology procedure in your hospital, Harapan Kita Women and Children Hospital. Next, I would like to open the discussion. I believe many of the participants have questions or thoughts that they want to share with the speakers. So I would like to open. Does anyone? Yeah. So one question from Dr. Ahmad Bayu Al-Farizi. Open questions to either any of the speakers, I think. What are the negative impacts of doing bronchoscopy to heart in mechanical ventilated cells? So I would like to serve the first question. Probably all participants can share the answer, but please, Prof. Sharm, probably would like to share your thoughts.
Yes, yeah, thank you for this question. The impact of the bronchoscopy in a ventilated child is well known, I think. There is lots of research done, especially what happened with the CO2 retention during the ventilation. So the diameter of the open lumen will decrease dependent on the size of bronchoscope which is inserted. So, and with an increased with a bronchoscope which is narrowing the lumen, for example, about 50%, there is a decrease in CO2 which you can measure. So at the end, it is in the ventilated child, it is has always a bad impact doing the bronchoscopy or doing the or inserting the flexible bronchoscope in a ventilated child. So you have to be aware of that. So what you want to do is you want to measure CO2, you want to see how much there is an increasing in the CO2, if there is a hypercapnia resulting, and if something will happen in the blood gas. And you have to be aware, even in children who are arcadial unstable, you have to be aware that this is a possible complication. I think this is all what you are mostly all what is happening.
Thank you, Prof. Schramm. Dr. Wahyuni and Dr. Rifan, do you have additional comments on that?
Yes, I think I fully agree with Professor Schramm, yeah, because as mentioned earlier, although there is no absolute contraindication for the bronchoscopy procedures, but we have to be aware of if there is like a severe hypoxemia, especially if it cannot be corrected with the ventilatory support. So when you're facing with children with the mechanical ventilation, you should also see how many % of the oxygens that the patients now are using. I mean the fraction of oxygen, because when you perform your bronchoscopy procedures, it will make that space more for the patients that can also make the complication happen. Thank you, Dr. Maudi.
Thank you, Dr. Wahyuni. Dr. Ivan, any additional comments on that?
Yeah, I think it depends on what the purpose of doing the bronchoscopy in the mechanical ventilated children. But if you have to do it, you have to do it fast, and you have to do it with good coordination with your colleague and doing the sedation. Yeah, but in our settings, usually in our setting in the PICU, I usually go to what first of all is what indication. Yeah, usually there is a mucus plug or something like that. But if the setting of the ventilation is already decreased, then I would ask them if it's possible to extubate first the patient first. But after intubation, we're doing the bronchoscope, doing the from the nose to the down level, and we are prepare also the ETT in the bronchoscope if there's something that going wrong, then we can intubate it right away with the scope guiding. I think what I edit is that. Thank you.
Thank you, Dr. Ivan. I would like to invite all participants to ask questions or share your thought. Does anyone to raise another question to the speakers, to the amazing speakers of today's lecture? Okay, while waiting, I would like to ask speakers, so open questions to all speakers. Oh, Dr. Darmawan has raised his hands. Dr. Darmawan, please, the screen is yours.
I cannot open my video. It is stopped by the host.
I think that is okay, Dr. Darmawan. Would you like to still?
Okay. Yeah, okay. Thank you, Prof. Sam, Dr. Wahyuni, and Dr. Ivan, for a very enlightening lecture. My question is for all speakers, and I think this question will represent many of the participants. You are all already presented it advanced in interventional pulmonology. Meanwhile, this procedure is not available in many of hospitals in Indonesia. My question is, can you, the three of you, tell us how to pioneering the facility of bronchoscopy from the 0 point? As I know, Dr. Ivan already seek the skill to the Taiwan, Dr. Wahyuni to China, and all perhaps Prof. Sam, are you the pioneer also in your place, or there are your senior that beginning the service in your hospital? Perhaps the three of you can tell us how to develop this, at least the basic bronchoscopy from 0 point, how to provide the tools, how to seek the skill, etc., etc. That's my question, Dr. Maudi.
Thank you, Dr. Daman. That is a very good question, a very applicable one that will be very beneficial for our participant. I would like to ask, probably Dr. Rifan first, then Dr. Wahyuni, and last but not least, definitely Prof. Sharm to share his experience. So how would you pioneer, how would you start a move that pioneer the bronchoscopy service in your hospital, Dr. Rifan?
Thank you, Dr. Darman, for the question. Maybe Prof. Sham will add some of it. The most important thing that I remember when Professor Wen Jusong, my teacher, said that if you want to do the bronchoscope or you want to start the bronchoscope procedures in your hospital, you have to have strong heart, like Kung Fu master, strong heart. Yeah. At the time, I was I laugh. I think just laughing. But during the time that I think what he said was right. Yeah. For now, because if you want to, we want to pioneering the bronchoscope services in our hospital. We have to have a strong, niat tuh apa sih? Yeah, strong will, and then we have, and then we have to have a good supportive team from the management and our college also that include. But now on, I think I'm glad that some of us in pediatric pulmonologists in Indonesia already start bronchoscopy beside Cipto Mangunkusumo and Harapan Kita. Also the Sarjito in Yogyakarta, Muhammad Husin Palembang, and Citra is in Riau. Pekanbaru also already started, but it's only a small thing, but it can be contaminated. Yeah. And then the very good how to start it is we have to learn from our expert, yeah, from abroad. I advise we go abroad, including to Professor Diksam to learn more about pediatric flexible bronchoscopy from only maybe a diagnostic procedure, or yeah, it's a baby step. Yeah, baby step. I think that's all that I'm comment. Thank you, Doctor.
Thank you, Dr. Rifan. Dr. Wahyuni would like to share or give us advice how to pioneer the service in hospital.
Yeah, thank you. I believe Dr. Darmawan actually already know our journey in Cipto Mangunkusumo Hospital, how to develop the service here. But I think when we want to start the services, first, of course, we have to have skilled personnel to do it. And after that, we also should have the equipment to support our procedures. So the first time when we are starting the service, first we should have to improve our skill. That is why at that time we attend bronchoscopy course, yeah, abroad, so that we can have the skill. But however, when we join the bronchoscopy course, usually it is only done in the mannequin or in the animal. So it's not directly to the human. So as a clinician, of course, we should perform it to the human. That is why when we are first time started this, we don't have any pediatric pulmonologists who perform the pediatric bronchoscopy. That is why we start to looking for the collaboration from our colleague from the adult pulmonologist who's done a lot of procedures. we learn from them, and then they can also help us to supervise our skill, and also we can lend their equipment. I think this is also happen in all over Indonesia. I believe in many hospital in Indonesia, they have adult pulmonologists. They have the pulmonologists who already had their services and their equipment. That is why in Indonesia we have the Perbronki. Perbronki is Indonesian Bronchoscopy Society. It is a collaboration between the Indonesian Pediatric Society and then the ENT Society and also the Adult Pulmonology Society. That is also what we are advocate through the society to help the pediatrician all over the Indonesia to support their skills and also the equipment from our colleague from the adult pulmonologist. Of course, the disease is different from adult with the pediatric, but at least for the technical, the skills and the equipment, we can ask them to help us while we are practicing and improve our skills in and focusing in the pediatric field. Now I think now it's become more and more, yeah, Dr. Rifan, yeah, because now we have the pediatric pulmonologists who perform the bronchoscopy, so we have a lot of fellows and also a trainee from other part of Indonesia that can learn bronchoscopy properly from the pediatric pulmonologist. I think that is all, Dr. Maudi.
Thank you, Dr. Wahyuni. I think my connection is slightly unstable, but I hope you can hear me. Prof. Shram, do you want to add another piece of advice to our participant that would like to start the bronchoscopy service in their hospital?
Yes, beside what already was mentioned, I think I would like to advise or recommend different thing. The first thing, it is a question of personal willing, as Dr. Rifan said. Look at Dr. Wahyuni, what she found here when she started, I think years ago, and what is built today. So this is an incredible way of initiating together with her colleagues, initiating things that will not running fast, going in baby steps, but these things are developing. If somebody said, I would like to do that, I want to do that, these are our patients, we have to be responsible for them, not any other department. So this is one thing. The second thing is, I think you have to know your own data. You have to know your own patient. Of course, nobody of us is able to make all the procedures in the same amount per year. Nobody is it. Because on the one clinic, this is specialized for lung transplant. The other clinic is specialized for pediatric oncology. And all these different departments in different clinics have different indications in these pediatric interventional things. So you have to know your own patient, and then you have to go in these skills, in these interventions who are needed in your home-based clinic. Because you become only good in things you are often performing, not in things you are less performing. If you are, for example, like me, I told this morning, we have only 3 to 5 indications for stent implantations per year. And this is not the number of cases where I do
Pak, udah makan? Udah makan belum?
Sorry?
It's okay.
Udah
Prof.
makan,
Shram.
Pak?
Probably the host can mute the leak voices.
Okay.
Host, Dr. Sriyanda, are you there? Okay, please continue, Prof. Shram.
Okay, so I think you know what I mean. So you can only become good with things you are often doing. And the last thing, the first thing is a personal thing. The second thing is your data. What kind of skills can you do often per year? And the third thing, you need a good networking. And there is a luck from my perspective, in our society, because our society was born much more in the internal medicine sorts. We were much more born into allergy, asthma, cystic fibrosis, preschool wheezing, and all these internal medicine things. And now, since 5 or 6 years, this specialization comes up. In the US, it led to the fact that the US are the people from the colleagues from the USA, they are starting now an own fellowship. They are doing 2 years of pediatric pulmonology and the 3rd year to become an advanced pediatric pulmonologist. That means 1 year fellowship only in the interventional skills. And I think for these things, we need a good network. That means we need a basis for our specialization. There is no really, we don't have our own society. There is no pediatric interventional society worldwide. There are some groups, there are some lonely groups working in the WABIP, there are some groups, some lonely groups in the European Association, and there are always some groups. So we have to we have to find a platform where we can come together, discuss about contents of the fellowship, discuss about the difficult cases, the complications, try to share our knowledge and do the publication so that people from all around the world can read what happened there. So sorry for my emotions, but I think this is where we have to go, from my perspective.
Thank you, Prof. Schramm, for the wisdom on how to pioneer pediatric bronchoscopies of interventional pulmonology procedure service in the hospital. I would like to apologize because I could not open my video due to a connection instability. But that will wrap up our international guest lecture for today. I would like to share my deepest gratitude to Prof. Schramm, Dr.
Dr.
Wahyuni.
Maudi, may I add something?
Yes,
Yeah,
sure, Dr. Darmawan,
Regarding-
please.
regarding my question already answered by the 3 speakers. I only want to stress what Dr. Wahyuni said. The one practical point is we are pediatricians and ask the help of the adult pulmonology or adult internal medicine respirologists to teach us, to train us how to perform the procedure. The other thing is how to get the equipment. This is another big thing, I think. Yeah? Some hospital already has the bronchoscopy equipment complete, but they have no the skill. But in the other situation, there is from zero at all, the skill, the equipment. Perhaps in this situation, we need to make approach to the manager, to the hospital management, that right now the pediatric bronchoscopy at least and would be advanced to interventional pulmonology is needed in the hospital, like other services such as the NICU and PICU. That's what I want to add, Dr. Maudi. Thank you.
Thank you, Dr. Darmawan, for another good suggestion for everyone, for all participants to start their bronchoscopy practice or pulmonology intervention. I hope that I am clear. Can you hear me, Dr. Darmawan or other?
Yeah,
Yes, clear.
Okay, I would like to wrap up today's international guest lecture because we have an amazing. Hello, yeah. Because we have an amazing speakers that present topics of interventional pulmonology procedures and share their wisdom on how to start your own a pulmonology procedure practice in your hospital. The highlight for today's lecture is, so interventional pulmonology is a field that needs to be developed rapidly in our country, Indonesia, to provide better care to Indonesian children in regards of pulmonary diseases. Many procedures such as bronchoscopy, cryobiopsy, balloon dilatation, thermal therapy, so on and so forth, are essential to overcome many respiratory cases, either in diagnostic or therapeutic aspects. And for everyone who wants to start the hospital bronchoscopy practice, please have strong will, strong heart, as Dr. Irfan said, and practice your skill. Make sure the equipments are there, and Shram, make sure that you have to know your data. Dr. Darmawan also add that probably good management and network, as mentioned by other speakers, are important to make the service successful in your own practice. So, speakers, do you have anything more to add before I close the meeting today?
I would just say thank
I
you.
don't believe that. So, Dr. Irfan? Oh, yeah.
Oh, it was
Prof.
me.
Shram, please.
It was me. I just wanted to again say thank you for this wonderful and well-organized meeting. This is really great to be here, and thank you very much.
Thank you, Prof. Shram. We are very honored to have you here. Also, Dr. Wahid and Dr. Irfan, and all participants that are joining in today's guest lecture. I would like to close our lecture today by saying thank you and good day for the rest of your day. Bye. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Very much, Prof.
Thank you,
Shram,
Dr.
Dr.
Wahyuni,
Irfan.
Dr. Maudi, Dr.
See you,
Darmawan,
Dr. Irfan.
Prof. Dirk. Yeah.
Waalaikumsalam.